Good afternoon. Want to thank Bill and Susan for extending the invitation. I know you've had a very nice day today, lots of really fantastic talks, very informative. And so just kind of as we get right before our panel session, talk about, something that we've all experienced in our clinical practice, and that's bleeding and strategies to address it. So, we can always say, what's a physician's first response to bleeding? And so some of the things that often we hear, when we'll ask our students this or our trainees this, as we're onboarding new ECMO specialists, the common answers are transfusions. Try to, maybe see if we can put a stitch in it, maybe hold some pressure. And so those are the common things. Sometimes we think about the anticoagulation issues and see, where we can, address things. When we think about, what are a surgeon's responses to bleeding, it kind of depends on the state that surgeon is in. And I know you guys have all spent a lot of time in the OR, and working with us. Sometimes we're in a good mental place, and sometimes we've been in a tough case, and we just, we need something to just make it go away. So, a lot of times we'll often say, this is, it's perplexing to me. I don't understand why it was bleeding. It was often dry when it closed, and sometimes. We're not being truthful with ourselves or the situation, it was a tough case, and perhaps it's more than just coagulopathy. Often we refer to it as a proline shortage sometimes. And so, but when you think about it, a lot of our colleagues, a lot of us that work in the OR, when we deal with the postcardiotomy patient, when we deal with a tough case, we've done as much as we can surgically. And so what are the things that we can do as we're transitioning off? It's a tough case. We're not able to come off pump. We have to switch over to ECMO and get them upstairs to the unit to recover. What are some of those things that we could do? Well, I think the first thing is to, really define this problem so that you've brought this patient on rocket fuel to the ICU, on a ton of stuff, on ECMO, the chest is open, there's probably a bunch of packing in there, and maybe 2-3 hours later you slowly see that packing or the S mark get bigger and bigger and bigger. And so, the decision is when to go back, what to do. And so, when we first see this problem, we have to kind of define it. And so ELSO talks about this and says, what's the definition of major bleeding? And so a couple of things that stand out, and that's, a 2-point hemoglobin drop in 24 hours. Or giving, one or more packs of PRBCs at 10 mLs per kg in a 24-hour period. And then obviously there's site-specific major bleeding on ECMO, CNS system, or the retroperitoneum. And then the other one that's important for us in our conversation today is things that require surgical intervention. So a 2-point hemoglobin drop or something that requires a surgical intervention meets the criteria for major bleeding. And then, again, why is this a problem? I mean, it's kind of obvious. Bleeding isn't good. Bleeding in the ECMO patient isn't good. But we when we really think about it, think about, how would we respond to that if your 5-year-old or 3-year-old was asking you why and just kept asking why? And so we have to really tease it out. And I think that's part of it. We should tease it out, all the little stems of it, and really address this. Bleeding is a common outcome, but a lot of different pathways lead to it, and as a result of that, you're going to have to address each and every one of them to really to mitigate it. So it's not just one pathway with one solution. Okay, so some of the topics that we're going to talk about today are, bleeding in the ECMO patient, the VA versus VV, central versus peripheral cannulation, what to do in the postcardiotomy open chest situation. When we're doing peripheral cannulation, should we do it percutaneously or open? And what kind of anticoagulation strategies should be used? So let's first start out here and take a look at how it impacts the VV patients. So ELSO Registry study came out fairly recently, this past year, and they looked at about 7,600 patients on VV-ECMO that were put on during the mid to late teens. And they found that the bleeding rate for VV-ECMO was about over 50%. About 37% had bleeding alone, and then 20% had that dreaded bleeding clotting combination. And then when we saw it, we saw that this bleeding rate was associated with an in-hospital mortality of increased in-hospital mortality, and then the risk factors for that were specifically for bleeding alone were acute kidney injury and the need for pressors, and then the combination of bleeding and clotting, or people who were put on in a prolonged pump run, and people, interestingly enough, that were done in the earlier part of the 2010s. So as the technology improved and maybe our practices have improved, there's been less instances of the bleeding and clotting. So when we kind of look at this data and we kind of see out here, the surgical site bleeding and cannulation site bleeding represented nearly 50% of the bleeding in VV-ECMO. And to me, this was kind of surprising because our VV-ECMO patients really don't bleed that much. And so, what's been going on? And I think a lot of this is a part of our approach and how we train our cannulators to try to minimize this, because we always get called back, and our desire to try to not come back to the bedside every 2 hours to deal with bleeding. But this is an important thing. And the important thing to think about is that, bleeding doesn't happen in a vacuum. So the solution can't just be, let's correct the coagulopathy, give a ton of products, because then you're going to push yourself over into the clotting part of that issue, right? So if there's a surgical bleeding, if there's bleeding from the cannula site on VV-ECMO, then, this is a technical problem that needs a technical solution. And oftentimes it's just like one stitch, and it should make it go away, maybe two. But I would say that, the reason that, we got there is probably one of the things that we're going to talk about. How did we get to that point? What could we do to prevent it? Well, that's one part. And then, now that you have it, how do you fix it? And again, so sometimes, when the bedside teams, our perfusionists, I appreciate it because we don't, I don't do all the ECMO cannulations, but when we have bleeding, they'll point it out. And oftentimes it's just something that we can address, because otherwise this is like a unit every other day of PRBCs that's getting transfused into this patient, or there's 10 inches of Surgisil powder on the cannulation site and it's still bleeding. And so, the teams are doing what they can, but the issue is that the cannulation hole was too big. I mean, it's as simple as that, right? It's a venous system. It shouldn't bleed otherwise. All right, so let's, we can take a look at, we talked a little bit about the venous bleeding and talk a little bit more about arterial bleeding. And this is where it kind of gets a little bit, more than just a simple purse string suture. So this was a study out of the Maryland group, and they looked at their experience with it. And, they had a fairly high bleeding rate, but this included VA, VV, and VA-ECMO patients. But all in all, the trend was that patients that bled had an increase in hospital mortality. And for every unit of blood transfused, there was a slight tick up in the increased mortality. So it's one component is just the blood products being transfused, but the other component is that, what's going on? What's the underlying reason that this patient needs to get blood products and continuously get blood products? And we'll kind of talk about there's a lot of deleterious effects of blood products. A lot of times we're trying to rest the lungs. Well, it doesn't really help to rest the lungs if you're going to give them trolley, while you're trying to keep them on ECMO. And then, part of this study, they found that their VA-ECMO patients had a significantly higher rate of bleeding. Now, this is a small study, and some of the rates of bleeding are a little bit high, but the point is that there was a statistical difference between VA and VV-ECMO in terms of bleeding. And so from this, they concluded that, increased PRBC transfusion is associated with increased rate of in-hospital mortality. So we can kind of look at this, and this is their study here, and can kind of see, what are the things that really stand out? Well, the things that are standing out are what do these patients have in common? The post-cardiotomy patients who are centrally cannulated on VA-ECMO, they had the highest rates of bleeding. And then they found that, it didn't really matter whether, what type of anticoagulation they used. That wasn't a statistical difference. It was just really this patient subset. And so, what is unique about this patient subset? Well, we know that they've had a pump run. When they were originally cannulated, the ECMO wasn't the thought. So potentially some of the cannulation strategies weren't meant for prolonged usage. The cannulas themselves weren't really the ones picked for the prolonged uses. The chest is potentially left open, and so that sternum is just hosing. And now you have to keep them anticoagulated. So these are the things that these post-cardiotomy central ECMO patients have in common. And so one of the things that we can kind of look at, and again, see this, that, they had a significantly increased bleeding events per 100 days. And again, the chest was the site of the bleeding. And so, and I'll argue for this, is that, whatever we can do to close the chest, get out of the OR, even if you have to do a temporary closure and come back, maybe put a couple wires in and then just plate the rest a couple of days later, it's going to be of benefit. So a closed chest leads to less bleeding, leads to more stability, less need for ongoing transfusions, quicker recovery. And again, the in-hospital, and we see this because the in-hospital mortality in these situations is high. The counter to that is that these patients are sicker, and that's why they needed this in this situation. But I think at our institutions, our practice is to try to move the cannulas to the groin and close the chest if we can. All right, another ELSO study. This one is a more recent cohort, about 15,000 ECMO patients, nearly. And they looked at, and this is pretty good survival, 44% survival on VA-ECMO. And second and third most common complications for VA-ECMO were surgical site bleeding and cannula site bleeding. And I guess if you consider renal replacement therapy a complication, which, it's a little controversial, they would then be really the first and second complications. And you can see that the drop-off in survival is there, especially for surgical site bleeding. It's nearly 10, 11-point drop-off in survival, so it's not insignificant. So, why do these ECMO patients bleed more? Why does VA patients bleed more? And the truth is, well, when we look at it, you see what are the causes that kind of put you in this cardiogenic shock. And we kind of touched upon this. Post-cardiotomy heart transplant patients, the VAD patients, these are patients that are anticoagulated, have had multiple surgeries, lots of exposed surface area. And so these are they have a reason to not be in a good situation. A patient with a cardiac arrest, things you crashed on. Things were done maybe in an expeditious manner, but not maybe as meticulous as you would be otherwise. And so a lot of the factors that these patients, do poorly is due to patient selection. A lot of times you can't really pick, right? You don't get to choose who arrests and who doesn't, or who's not going to be able to come off pump. But these are things that factor into it and are baked in. And so the only thing I would say is that if, when we're doing a hard case, a low EF patient, it's going to be a long pump run, you're not 100% sure, but you feel like, this patient's going to potentially struggle. Maybe as you're putting in your initial cannulation stitches, be mindful of that. Maybe think about, putting in a femoral venous line instead of a right atrial line, because, hey, I'm probably going to come out on ECMO. Might as well do that. So those are things to think about. Again, the goal is to hopefully, if you're going to come out, maybe put in a femoral cannula, put in a distal perfusion. You already have your, multi-stage drainage cannula that was in the heart. Maybe you can pull it back a little bit, position it for ECMO, and then you can close the chest. And now that's one less thing to worry about. A, you don't have to come back to close the chest. B, the bleeding is going to be much less. An open sternum is just going to bleed and bleed and bleed. ELSO released its management guidelines for VA-ECMO patients recently. And so some of these things to kind of think about is the cannulation strategy. And they talk about this, and this is a nice chart. And this isn't anything that you guys don't know, but when we compare central cannulation, it does have its advantages. It's a nice big cannulas. You can really unload the heart. The heart can be emptied. You can get some great flows. You're never flow limited, right? It's never that the femoral cannula is too small, drainage cannula is insufficient. You can match whatever the cardiac output of that patient is to keep that heart completely, rested. And if you need to put an LV vent in, well, the pulmonary vein's right there. You can throw it in. You've completely addressed all the potential issues. The downside is that, the bleeding risk is the highest out of all of them. And then you also have risks of stroke and infection and things like this. But for the purpose of this talk, the bleeding risk is higher. And again, it's because of that sternum and the raw surface area. Now, when we look at the peripheral cannulas, there's lots of different strategies for arterial sites. And so, the common ones we can kind of talk about or break it up into femoral and an upper body cannula. That's either an axillary or subclavian with like a graft usually. When we look at the femorals, and we'll kind of talk about this in a separate study, but the femoral approach can either be done open or percutaneous. And I personally will vacillate between the two because there's pluses and minuses for both. But in terms of bleeding, the femoral has the lowest bleed. Percutaneous femoral sticks have the lowest incidence of bleeding. And they also have a lower incidence of infection, and that's because there's no surgical incision. And so those two things are great. They do have a higher incidence of leg ischemia compared to an open femoral approach. And frankly, with an open femoral approach, there's probably the leg ischemia rate should be 0 because everything's right there. You should be able to put in your distal perfusion cannula. As a plug for that, I think every program that does VA-ECMO should have some sort of limb management strategy. Our institution, we put in distal perfusion cannulas for everybody in NEERS. Some institutions do it selectively and monitor very closely. Whatever your institution's thing is, the surgeons, the clinicians that put people on VA-ECMO should adhere to that. To try to mitigate against leg amputation, limb loss. That being said, again, open itself has added benefits of, again, reduced bleeding compared to central access. The sternum is closed in all of these situations. And then axillary artery cannulation is a benefit, especially if you're dealing with some north-south flow issues and other things like that. But it has its own issues and its own drawbacks, and namely the one is that it's bleeding while lower than central open chest bleeding. There's still a relatively high rate of bleeding and need for reoperation. The brachial plexus is right there. You can get compression from a hematoma. We routinely leave drains in and invariably end up going back at least once a week to evacuate the hematoma, and just curse ourselves for having done this. But sometimes you need it. Because this happens at a somewhat frequent rate, an alternative to using the axillary position is to just do VA-ECMO from the femoral and then just put in a right IJ or some sort of other upper body return. And that would address most of the issues. The select times that we really push for axillary cannulation are when we're trying to bridge our patients to lung transplant or something where it's important for them to walk. Some sites have been able to walk people with femoral artery cannulas. We're a little bit skittish about that, and so we feel that the axillary position's a little bit better, but I think that's a very selective instance of, or specific indication for using the axillary artery. There are drawbacks to the axillary artery cannulation. Again, the higher risk of bleeding, there's higher embolic risks. Sometimes you'll get hyperperfusion or overflow to the arm, and that right arm will just swell massively. And these are things that, a lot of times when you're doing aortic surgery, you don't experience because it's a short pump run through the axillary position. But if there's any technical mistakes or even the trajectory of your graft, the size of your arteriotomy, if the sutures aren't as perfect as you normally would want them, a long ECMO run in the axillary position will punish you for every single technical error that you've made. Things that you don't, maybe you take for granted in that, 2, 3, 4 hour ascending case. There you're on and off, no big deal. This thing, if you're gonna be on it for a week or two and there's a little, the sutures aren't perfectly put on, or or the arteriotomy is too big or something like that. It's really hard. And so it's just something that takes technical experience, precision. So some takeaways, again, some clinical pearls. The subclavian axillary position, another indication for using it outside of, bridging a patient is if they have bad femoral access. And a lot of times, we, especially in the post-cardiotomy patient, if their hearts aren't doing too great, probably the vessels in their legs aren't great. So this might be a good indication to put it in the upper body. And then again, try to transition to peripheral approaches. The ELSO book talks about this, and pretty much everybody who's experienced an open sternum will show you that these things bleed and bleed. So we kind of touched upon this, the femoral ECMO cannulation, and the pluses and minuses of percutaneous versus open. This is, probably a little bit of this is practice specific, but as we look at the data, you can clearly see there's some data to support percutaneous cannulation. So when they looked at the registry here, they looked at about over 12,000 patients, and compared the percutaneous to the open, and found that there was a lower incidence of in-hospital mortality and lower cannula site bleeding with the percutaneous. And so that's pretty interesting, and I think something that we as cannulators should really be mindful of. And it's helpful sometimes for the teams to remind us, especially if somebody's a little bit less experienced in this space, that if you can do it percutaneously, it's probably worth trying. Sometimes it can be a little frustrating, especially getting the distal perfusion catheter in. And so believe me, I've been there. I understand. We work really hard to try to get the wire down the leg before we put the femoral arterial cannula up in the antegrade fashion. I think it's a lot easier to do it that way than to do it afterwards. Afterwards, the vessel is super small. You're on a bunch of pressors. It's, some of our vascular surgeons even struggle getting it in that. Obviously, the one caveat is that the limb ischemia rate, and this is a statistically significant finding, is higher with percutaneous. And I think it's namely due to the fact that that there's times where you think the cannula is in the SFA, the distal perfusion cannula is in the SFA, and it's not. And so this is I think attributes to that. But interestingly enough, this is when we look at their data. Again, you can see better outcomes in terms of in-hospital mortality and cannula site bleeding for the percutaneous. And then the other one that's a little bit interesting is systemic infections. And so there was an association between cannula site bleeding and systemic infections, and then need to re-intervene. And the authors concluded that this was because as you re-intervene, you reintroduce or you give an opportunity for the colonized bacteria in the groin to reinfect that space. And so, just like anything else, we take the central lines out of the groin when we can. If you make a big incision to expose a femoral artery, now you're in there, there's some suture material in there, maybe you have to put a pledget in there or something like that. There's foreign material, and so it can bleed. So now as we transition to anticoagulation, we talked about some of the surgical approaches and what we think about. As we transition to the anticoagulation, let's talk about, how we can tailor these things for the type of extracorporeal support we have. And that means, tailoring your anticoagulation for VV versus VA-ECMO. What's the patient's underlying disease? What are we trying to address? And then what's the current clinical situation? Can you run ECMO without anticoagulation? The answer is yes in certain situations. How long can you run it? Indefinitely, I guess, depending on how many oxygenations you want to switch out. And then what are the risks of running people? And this is specific, VV ECMO can lead to DVT formation, but VA ECMO situations of running people off of anticoagulation and the risks of, stroke and embolic event and how you can mitigate or balance against that. So risk factors for bleeding in VV ECMO patients. This was a study that kind of talked about the PTT. And so, not so much focusing on the VV ECMO aspect of it, but the PTT aspect. Single center study, so it's small, but they found that there was an association between bleeding complications and elevated PTTs, but not with low platelets. And this was a theme that we can kind of see throughout some of the data that shows that peak, not adhering to the nomogram, the anticoagulation nomograms, or having levels that are markedly elevated, the whole PTT greater than 180, having several instances of those things has been shown to have increased associations with bleeding complications. So that's just something to think about. And what that really means is just strict adherence to the protocols. So when we kind of look at the major complications in the VA sphere, we look at the hemorrhagic complications, and you see that, anticoagulation is a way to address that, and managing the anticoagulation. And the other thing is avoiding unnecessary invasive procedures. Well, if you can avoid the bleeding, that helps a lot. So let's talk a little bit about anticoagulation. The ELSO anticoagulation guidelines call for adherence to a strict protocol. Whatever your institution's protocol is, you need to adhere to that, and specifically try to avoid those peaks in anticoagulation, abnormal lab values. And then this isn't from ELSO, but the anticoagulation pathways are complex. Our understanding of it is still limited. And so the drugs that we have work in the different parts of the pathway, but we've all been in situations where the lab values are discordant, the patient is bleeding, everything's, and hypercoagulable at the same time. The circuits are clotting off and they're bleeding. And oftentimes those things herald a bad outcome where they're bleeding and clotting at the same time. That's usually a harbinger of something bad. But a lot of that is due to the fact that we just don't understand all that parts of this cascade, and the medications that we have work in various aspects of this cascade. But this is a little bit more nuanced than sometimes we give it credit for. So just a quick primer. These are the common medications that we use to anticoagulate patients on ECMO. We have our heparin, our bivalve, and our argatroban. Bivalve has the shortest half-life at around half an hour, and then it goes to argatroban, and then heparin at the hour to hour and a half. Heparin is fairly ubiquitous. It tends to be the cheapest when it's available. And then obviously it's reversible with the protamine. It's helpful. It does have the side effect of having instances of HIT, as depending on where you look in the literature, up to 5%. Bivalve it reversibly binds to thrombin. It doesn't require antithrombin 3, so your T3 levels don't have to be checked and addressed. But it has its drawbacks, and it's not good in patients with low cardiac outputs, low flow states, because when it lingers, it gets broken down by the proteases in the serum. And so you can have an abnormally non-coagulated or thicker blood than you think, because there's some bivalve that's just pooling in the heart or the aorta because it's not being ejected. And then obviously when we kind of look at these things, bivalve is renally metabolized partially, and argatroban is mostly hepatically metabolized. So if somebody has hepatic or renal dysfunction, then you'd have to adjust for it. But these are often the things that we would use in patients with HIT, and then more recently in patients with our COVID population, we've been using exclusively bivalvutin for our VA-ECMOs. Again, because of the stasis issues, it's a bit of a case-by-case basis in a VA-ECMO patient, because you just have to think about what the underlying reasons are. So some clinical pearls. Factor VII is not just for the aortic surgeons, although at our hospital they use like 97% of it. We can use it in select instances. Bivalve, again, if you're having trouble, bivalve's half-life is very short, but if you're having trouble clearing it and you need to do some sort of emergency procedure, CRRT can be used for that, or plasmapheresis. Again, in low flow states, people with low cardiac output, you want to avoid this because it'll break down locally, and then you can be at higher risk of intracardiac thrombus. Similarly, it can break down around the distal perfusion cannula, and you'll have to either switch it out, which is really problematic. So in patients that are in these potential states, bivalvutin is probably not the favorite treatment or management for VA-ECMO. So we can kind of look at the different ways of monitoring this, and this is the tried and true, what we have in the OR, the ACT. It is, it's great for monitoring the heparin dose, especially in the OR. You get it right away. But obviously, as you can see, its disadvantages is affected by a lot of things because it's measuring the end product of the cascade and not direct heparin function. And then it doesn't really have any role for the direct thrombin inhibitors, the bivalent or argatroban. PTT, outside of ECMO, it's probably, up there in terms of management of heparin drips in the hospital. In the ECMO situation, it's been gaining favorability or it's becoming more popular. Obviously, it's widely available, but it's a send-down lab, whereas if you're doing a remote cannulation, we have an ACT machine with us, so we give a dose, and then we have that machine with us, and if we have to give more as we're going back to the main hospital, we'll give more heparin, but we wouldn't be able to do that with PTT. We can't check it in the middle of the ambulance. There's some issues with standardization with PTT and some variability in the data, and then at the higher doses and higher concentrations of the direct thrombin inhibitors, it's less efficacious and less reliable. And then we have the factor 10. This measures direct heparin function, unlike ACT, which measures it downstream. Obviously, you can't use it for the direct thrombin inhibitors. And sometimes there's some variability in the assays and the calibration of the machines. Sometimes at our hospitals, we've had experiences where the levels have been all off, and we've had issues with our VA-ECMO patients. We'll talk about, I know there's a TEG talk later this afternoon, so I won't touch on this, but this is just, this is a new and shinier toy. I think all cardiac surgeons like newer and shinier toys. At our hospital, we're only allowed to get this in the OR, so on our lung transplants, we'll just ask for the anesthesiologist to send this as we're leaving, just so we have it. It gives you the whole picture, lets you see, what things need to be replaced and repleted. But obviously, it's expensive, it's limited, and so you can't really use this reliably on outside the OR and the ICU. So, what are the lab monitoring schedules? Obviously, ACTs can be checked very frequently, and then less frequently for PTTs and 10As, and in patients that are not bleeding, they don't need to be checked that often, once a day. And then this is a nomogram that ELSO gave for suggested titrations based on 10A levels of your heparin drips. But the thing to kind of think about is, what happens when the 10A level and the PTT don't match? And these are kinds of tricky situations. And so, if we look through this here, our 10A level is low, but our PTT is normal. Well, the recommendations are to increase the heparin. Or conversely, like if your PTT level is low, but your 10A level is normal, then there's a concern that there's an underlying hypercoagulable state that you're not addressing. And so you want to kind of use both of these lab values together. So especially if the clinical picture isn't aligning with your 10A levels, then it's good to check a PTT and just make sure that both of these things are kind of reading off the same hymn book. So some takeaways for VV-ECMO anticoagulation. Recently, there's been tendencies to run patients with minimal to no anticoagulation. I think the one exception would potentially be COVID, and even in those situations, we run patients a little bit lower. We use bivalve, but we don't run very high PTT targets unless they have specific instances of hypercoagulable issues, or we're having to change out the oxygenator frequently. But outside of those specific cases, for just your run-of-the-mill VV-ECMO, there's been a lot of studies that have shown people on ECMO for months, being bridged to lung transplant or whatever, and they've been off of heparin. And it minimizes transfusions, especially when you're bridging somebody. You don't want to sensitize them by giving them a unit of blood every other day. So this is an important thing. Again, so lower targets are safe, and there's instances of being able to do it without the complications. If you saw some of the earlier studies, showed really high bleeding rates in it, so it shouldn't really happen. You shouldn't be getting this type of bleeding in VV-ECMO patients. Now, for VA patients, this is a little bit different, and the also recommendations were that you still have to run them on anticoagulation. That being said, there's been some studies that show that it's safer to run them short. And we've experienced this too, where again, you have a postcardiotomy patient, they're bleeding, they're on VA-ECMO, we can't anticoagulate them because they're bleeding. So we'll have to just kind of suck it up. And a lot of times those patients, are fine and don't have any sort of embolic event. Also, we stop the heparin for like trachs and procedures and things like this, and so we're thoughtful about that. Transfusion triggers, if you kind of think back in the day, people were getting transfused to like hematocrits north of 30, 35, and everybody was getting like platelets to keep them at over 100,000. And so ELSO's released newer guidelines, and I think this is, more along the lines of where most programs are, kind of that hemoglobin target of 7, 6 sometimes in our bridging patients. And then platelets, depending on the clinical situation. If you're not bleeding, you don't need to just make that number 100. It can be okay as long as it's not, markedly low. So just kind of things to think about. Trying to keep it a little bit more conservative, again, because adverse things happen with blood product transfusion. It's not a risk-free endeavor, especially if you're trying to get them off. You don't want to trash their lungs with blood products. Okay, so what is the clinician's responses to minimize the bleeding? We've kind of talked about this. Anticoagulation protocols to minimize bleeding with that in mind. Modern transfusion targets, so we're not transfusing everybody for lab values, but transfusing them for the clinical situation, and adherence to protocoled anticoagulation pathways. So what about a surgeon's responses? How do we think about it? Again, remember we kind of talked about this a little bit at the beginning, but patient selection is a huge factor. If you can plan ahead of time what you're going to do, if it's going to be a tough case, we image the legs. We think about what is our cannulation strategy going to be. This is a patient that we're looking at for lung transplant, and if we think that they're going to need ECMO post-op, we plan for that. Case selection, and then what cannulas you're going to use, and how you're going to approach that, and we'll kind of talk about that. And then timely response. If we just sit there and watch them and just give tons and tons of product to get them to the next day, eventually this product's going to catch up with you and you're going to get trolley. So if you're having bleeding and it's surgical bleeding, the appropriate thing is to go back that night and deal with it. And not try to just get them to the morning and correct the coagulopathy. And we remember this because this is the trolley pathway. It happens each unit of blood, and then it just starts seeping in. And we've seen this. The lungs will wide out, and then now you switch from VA-ECMO to VV-ECMO. Once the heart recovers, you've made it through that portion, but now you've trashed the lungs with all the blood products you've given them. So they're going to be on ECMO for another 2 weeks. So again, we've talked about this, but these are kind of like the things that we adhere to when we talk to our trainees and our cannulators. We try to push for percutaneous techniques when possible. We use if we do an open procedure, we'll put in a Prolene purse strings around our cannulation sites, and then we use kind of these disposable tourniquets, Ramel tourniquets, that we will have buried in the groin when we close the incision. But it snugs up against the artery and the cannula. We use the smallest cannula as possible. So, certainly not everybody needs like a 20 French in the groin for 3 liters. But sometimes we'll get them transferred in from another hospital, and that's what the cardiac surgeons put on. And so we'll try to downsize it and repair it and resite it. So the smallest cannula possible. Sometimes this avoids, needing to put a distal perfusion catheter in. If you only need to flow 2 liters, maybe you don't need a huge cannula, and maybe you can obviate the need for a distal perfusion cannula. All the venous sites should always have purse strings. It's a low flow state. You should always be able to put a purse string on it. We intentionally make our skin incisions very small, and then put a purse string around it. And because we've seen otherwise, sometimes people are a little bit reckless and will make take the 11 blade and make a 1.5 centimeter stab incision. It makes it very easy to cannulate, but then, once the cannula is in, even if you have a big 29 French multi-stage, there's still another centimeter of incision that now you have to close. And so it's like anything else. You have to put a stitch in it. So if you, A, can avoid making the incision so big, that's great. And B, we always teach them to put a purse string around it. There's an obvious risk. The downside of this is that somebody invariably was going to put a needle through the cannula. I haven't seen it, but some of my colleagues, swear that they've had trainees do that. So those are things to kind of be cognizant of. But I think, we take brand new cannulators and they do this and we watch them and it's been fine. Arterial cannulation, you can overdilate the vein, but you can't overdilate the artery. And so you have to be mindful of that. So you have to know what cannula you're going to put in that artery, and you can't overdilate it. Because if you do, it's just going to bleed and bleed and bleed, especially if you go percutaneous. Well-secured cannulas. We've had the floating cannulas. Every time we get a patient from another hospital, again, the neck cannula is floating, or femoral arterial cannula is floating. Especially the arterial cannulas, a lot of them are tapered. So if they're not secured, they're going to be dilating and going in and out of this artery all night long, and then it's just going to be bleeding around it when it backs out. So we work really hard to make sure we don't overdilate, and we secure these cannulas with tons of suture. And then sometimes, you're in a really bad coagulopathic state, and every needle that you put in, that site will bleed too. Well, a trick to that is to take a smaller needle, like a 5-0-proline, and oversew the needle site. We've had to do that a couple of times, but it works and it's effective. It's just the same way that we would deal with bleeding, inside the chest. But the solution for bleeding shouldn't be to just watch it. You have to do something proactive about it. And then, what about resiting? If there's an issue with the leg, something's going on, it's okay to move it to the upper body. You have a fresh start, you can work on it. And then the big push is to always try to move the cannulas peripherally if you can, so you can close the chest. So again, techniques, thoughtful planning, think about what you're doing ahead of time, pick your approach, pick the cannulas that you're going to use, and then try to, really think this through. So kind of in conclusion, as we go through this, we have to identify our sources of our bleeding. Is it coming from the cannulation site? Is it coming from the surgical procedure? If, depending on what it is, we need to address it. We need to have a low threshold to intervene. We can't put our head in the sand and think that it's only coagulopathy. If it's surgical bleeding, it's surgical bleeding and needs to be addressed. And then lastly, unrelated to this talk, but, having done this for a while, I've got a great appreciation for the work that you guys do, and for the competency and the ability to work in a high stress environment and make a good product every time. Just the other day, we're doing a D-cord on a patient with a low EF, and the patient became unstable, and even without asking, there was a perfusionist wheeling in the ECMO circuit, and they were ready to go. And so it makes, I think, a lot of CT surgeons feel very safe. It's like having a warm blanket if you were a kid. Your perfusionist is there, and they have a circuit that's primed. And so we've seen it when we go transport with our transport program's pretty busy. We use our perfusionists instead of our ECMO specialists, because these are high stress environments where you're kind of by yourself. And we've had circuits deprime, we've had circuits clot off and have to have somebody reprime a circuit in another hospital, and so, while we're dealing with a lot of instability. And so it's good to have somebody that knows it, who's been through it. As you guys know, and I don't need to tell you this, but these are all the things that can go wrong on an ECMO circuit, right? And all of them are fatal, and all of them need to be dealt with expeditiously. And the solution for all of them is to change the circuit, right? And or mostly. And so what that means is that to be able to do this, you have to do this quickly and have to have somebody that knows what they're doing. And so I just want to thank you guys for your contribution to our patient care.
Thank you, Dr. Javidfar. So if you would go ahead, thank you, excellent talk. If you'd go ahead and move our chairs in place for me, we'll have our panelists come up. For those, hopefully you have, I know it's getting, everyone's kind of